Klein here with OSMS in Green Bay. I want to thank you for joining us this evening, and we're going to be talking about common causes of shoulder pain, some of the most common things that I see here in my office, kind of our treatment approach, how we work out patients, how we treat them both conservatively and surgically, and also some of our policies here at the office for managing COVID. I know that COVID policies and issues are in the front of people's minds when it relates to their health care these days, and we have put in place policies to make it as safe as possible to both be treated in the office and also to have surgery. Going back to March of last year when the pandemic first hit, we did have a near complete temporary shutdown here at the office, and we're only able to do urgent or emergent surgeries at that time. All elective surgery was put on hold, and we slowly came back from that, reopened the office, got back to doing elective procedures once we were able to put appropriate policies in place to keep people safe. So some of the things we're doing today: we perform temperature checks and require masks for all patients, guests, and team members inside the building. We have social distancing signs in the lobby. We have enhanced disinfecting, sanitizing, and cleansing procedures. Visitors are limited to those who need assistance or for minors, and telemedicine visits are now available for some of our established patients. Next thing people want to know is, how safe is it to have surgery during a pandemic? All local hospitals, including our surgery center here, the Green Bay Orthopedic Surgery Center, have implemented policies and safety measures to allow for the safe performance of surgery. For all elective patients, you're required to take and have a negative COVID test before your surgery, and you're asked to quarantine before the surgery after your test. For anyone that tests positive for COVID, we require a 28-day waiting period before you can get back on the surgery schedule. We use the appropriate personal protective equipment. We have enhanced disinfection practices utilized. Visitation is limited, and masking and social distancing is practiced. Our guidelines continue to be monitored, and safety of the patient is always our first and primary concern. So with that out of the way, a little bit about me and my practice. I grew up in Houston, Texas, went to medical school at Baylor College of Medicine, did my orthopedic residency training at the Mayo Clinic in Rochester, Minnesota, did a sports medicine fellowship in Houston, where I had a chance to work with some of the professional teams and athletes there. I was in a practice in Waco, specializing in sports medicine and general orthopedics in Waco, Texas for 4 years, and moved to Green Bay and joined OSMS back in 2005. I currently see sports medicine and general orthopedic patients both in our Green Bay and Marinette offices. So tonight what I want to do is talk about some common causes of shoulder pain, explain what to expect with an office appointment, conservative treatment approaches for non-operative shoulder problems, some of the things that we consider for surgery, and how to decide when surgery may be appropriate. Some of the things you can expect after surgery, some of the protocols that we have, and what to expect for your recovery. And I will touch a little bit more specifically on rotator cuff overview, because that tends to be some of the most prevalent questions that we get. So I want to remind you, as you're listening tonight, if you do have questions, to go ahead and type them in, and we will do our best to get to all the questions that come in. So if we look at the common cause of shoulder pain, they can be generally broken down into two separate groups, those being atraumatic, or occurring without an injury, or traumatic, in which a very specific injury is involved. So when we think about traumatic injuries, we look for things like fractures, rotator cuff tears, labral tears, biceps tendon tears, dislocations of both the shoulder joint or separation of the acromioclavicular joint are some of the most common traumatic shoulder injuries that we see. Traumatic injuries, or those that occur without an injury, or atraumatic shoulder pain that occur without an injury. Some of the most common things will be a bursitis, rotator cuff tendonitis, biceps tendonitis, impingement, which is basically pinching of the bursa and the rotator cuff, and it can have to do with the way your bony anatomy is set up. Glenohumeral or shoulder arthritis we see in atraumatic situations. Acromioclavicular or AC arthritis. Adhesive capsulitis, or otherwise known as a frozen shoulder, is another thing that we see that occurs oftentimes without any specific injury. And one thing to look for or keep in mind is cervical radiculopathy. I can tell you that I see every day in my practice patients that come in complaining of shoulder pain, especially pain that occurs in the back of the shoulder or along the shoulder blade, that turns out to not be involved with the shoulder at all, and it turns out that it's the neck, a pinched nerve, a herniated disc, arthritis, some reason or abnormality in your neck that's actually causing your shoulder pain. So that's another thing we have to keep in mind and look for. So the first thing we do if you do come into the office is we obtain a history. That's kind of the key to making any medical diagnosis, is to get the story. We look for things like a specific injury, like I mentioned. We want to know about the duration of symptoms, how long they've been present, the location of the pain, where does it hurt, exacerbating activities, things that you do that cause the pain to either be there or to be worse. We look for neurologic symptoms, which can kind of clue us into the neck being involved, and these would be things like numbness, weakness, or pain further down your arm. Anything that goes past the elbow oftentimes indicates a problem with your neck. It's important to know if you've ever had the pain before. Is this something that just started, or have you had this pain in the past? Maybe you've been treated for it, maybe you've had injections, maybe you had pain that went away on its own and now it's back, but that's an important part of the history. Of course, we want to know about any previous surgeries that may have been done, because that helps lead us down the correct avenue for a diagnosis. And anything that you may have done to try to intervene or treat yourself. So using anti-inflammatories, any kind of exercise you've done, if you've already been to see a physical therapist, if you've seen a chiropractor, acupuncture, anything that you may have done to try to modify the symptoms on your own, that's also a very important part of your history. So after we get the history and your story down, the next thing we do is we like to do a thorough exam and looking for very specific things. The first thing we do is just a simple observation. We look at the shoulder, we look for any evidence of swelling, bruising, atrophy of the muscles, any redness or any signs of infection, any outward abnormalities, any skin changes, anything else that can kind of lead us down the diagnosis path. We check for your range of motion. We like to see how high you can raise your arm, how far you can rotate it, can you bring it behind your back. We test for strength, especially when we're looking for rotator cuff injuries. A strength test is very important to see can you resist external rotation or turning your shoulder outwards? Can you raise it up to the side against resistance? And a good strength test will give us a lot of information. We look for stability. We look for any evidence that you may have a loose or unstable shoulder. And to the other extreme, we look for any evidence that you may have a frozen shoulder, or your motion being restricted by an adhesive capsulitis or tightness around the shoulder capsule. Then there's very specific tests that we do for certain diagnoses, looking for biceps tendon tears, looking for impingement, looking for rotator cuff tears, looking for cervical radiculopathy or a spine condition. There's specific tests that we do for that. It's very common, and almost always we'll start out with x-rays in the office, very specific views looking for different things. X-rays will give us the most information when we're looking for arthritis, when we're looking for fractures after a trauma. Those x-rays are usually the easiest and best ways to make those diagnoses. Occasionally we order MRIs. MRIs are good at looking for soft tissue injuries, for rotator cuff tears, for biceps tendon tears, for labral tears. MRIs can be done with or without a dye injected into the shoulder. So for certain conditions, especially labral tears, we'll have a contrast dye injected into your shoulder before the MRI, and that will help to give us a better look at some of the soft tissues inside the shoulder, give us a better chance to pick up the small tears or the more subtle diagnoses. Occasionally we will order CT scans. CT scans are good at clarifying bony anatomy. They give us more information than an X-ray can, especially if we're looking for bone loss with arthritis, if we're looking for subtle fractures, if we're looking for displacement of fracture fragments. CT scans are sometimes ordered and give us a good look at the bony constructs in a little bit better detail than just X-rays alone. So when we see what we consider non-operative shoulder pain or shoulder problems, the first thing we think about is what conservative measures can we take to try to treat the problem, make the shoulder better. And the first thing I always talk to patients about is modifying activity. So if there's anything specific that you're doing during the day that you know is going to cause pain, it only makes sense that if you avoid those specific activities, that's the first thing to do to try to get on top of the pain. If you've been overusing your shoulder, either with lifting or throwing, any kind of daily activities, repetitive daily activities that you've noticed have either caused or contributed to your pain, the first thing you do for conservative management is just eliminate those activities or change the way you're doing these things. The next thing would be over-the-counter medications. These would be your anti-inflammatories, your Advil, ibuprofen, Motrin, Aleve. For those that can't take anti-inflammatories, sometimes Tylenol. It's good to try those things if you have a shoulder problem that comes on, especially if it comes on without a specific injury. It's something that you can do on your own even before you come to see us, and it's something we may prescribe for you depending on what diagnosis we make. Physical therapy is sometimes ordered, especially in the case of partial thickness tears of your biceps tendon, your labrum, or if you have a generalized muscle weakness around the shoulder. Physical therapy may help to improve that. Injections are sometimes given, especially in the setting of inflammatory causes of shoulder pain. That would be your bursitis, your rotator cuff tendonitis. Sometimes we inject for labral tears, for biceps tendon tears or biceps tendonitis. These things can all sometimes respond to injections. Home exercise programs can be done on your own at home. One of the best ways to do those is with elastic tubing that can be picked up at the pharmacy. Really any sporting goods store would carry elastic tubing, and a home exercise program with that or free weights may help to eliminate some of your atraumatic type pain. In formal physical therapy, oftentimes we send people for formal physical therapy to address specific causes. Depending on the history and the exam, immobilization, either with just a straight immobilizer, bracing, or a sling is sometimes required, especially for shoulder problems that just need a rest. And sometimes we'll see patients in our office that have a minor injury and maybe pain that's going to get better if you just give it some time. So we may try a sling for a week and then reevaluate a week later. Surgery. There's certain shoulder problems that respond best to surgery, and some of the things that we look for is acute trauma. Some specific fracture patterns require surgery to stabilize the fracture to make them better, but fractures would be one of the leading causes for people to require surgery. full thickness rotator cuff tears, and I'm going to discuss tears in a little bit more detail shortly. Dislocations of the shoulder, especially recurrent dislocations, and we know that the younger patients are, when they have a first dislocation, the more likely it is that dislocations will become a recurrent problem and may require surgical stabilization. Separations of the shoulder will occasionally require surgery as well. The other time we consider surgery is for failure non-operative treatment. And so if we see a partial thickness rotator cuff tear and we try activity modifications and anti-inflammatories and physical therapy and injections, and the pain continues, or if the tear progresses, and we'll discuss that again a little bit more later, but that may be a reason that someone would require surgery for their shoulder. Labral tears, that's the cartilage that surrounds the inside of the shoulder. When it's torn, it may require surgery. Biceps tendon tears or subluxation. The biceps tendon is a tendon that attaches inside the shoulder joint and exits through a groove in the shoulder. And if that tendon is coming out of that groove, that may be a reason that you would require surgery. Chronic impingement and bursitis. So this is pinching and inflammation of your bursal tissue that's between your rotator cuff and the acromion, which is the bone sitting above the shoulder. If that becomes chronically inflamed or thickened, or becomes a recurrent problem after treatment that makes it better, we may try an injection and it works, and then the pain comes back, and we may eventually consider surgery for that. One of the common questions, if I have shoulder surgery, what can I expect? I mean, what is my recovery going to be like? That is a kind of a broad question, and one that's difficult to answer without knowing exactly what the surgery is being done for. But oftentimes, when we're talking about shoulder surgery, we're talking about either a repair or no repair. So either a rotator cuff repair or a problem where you just have a shoulder scope, maybe a labral tear debrided, a partial thickness rotator cuff tear debrided. And so whether or not you have a repair versus no repair will oftentimes dictate the extent and length of your recovery. Repairs can require sometimes up to 6 months to be better. Rotator cuff repairs are generally a 5 to 6 month recovery. Labral repairs are about the same in the 6 month range. Biceps tenodesis, where we detach the biceps tendon inside the shoulder and reattach it outside the shoulder, can require up to 3 months of recovery. If you have your shoulder scoped and cleaned up, debridements, bone spurs removed, and no repairs, we're generally going to have you back to doing most activities within 6 weeks. The recovery is much shorter. The rehab is more aggressive. Oftentimes you can get back to using your arm very quickly. We might have you in a sling for comfort, but you can come out of the sling when you feel comfortable doing so. And activities are basically increased based on your level of comfort. So one of the most common things we see people for, and we took some questions prior to tonight's talk, and a lot of the questions were involving rotator cuff tears. So I thought I'd spend a little bit of time here discussing rotator cuff tears a little more specifically and in depth. Rotator cuff tears are very common in society, and they're increasing in incidence. We know that they increase with age, to the point that as we age into our 60s and 70s, it's very common to have at least partial thickness tears of your rotator cuff and not even know it. So if we took patients in their 60s and 70s and ran them all through an MRI scanner, we would actually find quite a few patients that have some partial thickness tearing of the rotator cuff and really don't have any idea that it's there. The rotator cuff is a group of muscles that originate on the shoulder blade or the scapula, and they come out and attach on the humerus, the top part of the humerus. The rotator cuff is responsible for your ability to use your arm in space, and so any activities away from your body, lifting, overhead activities, these all require your rotator cuff for proper functioning. So common symptoms that we'll see with rotator cuff injuries: pain, weakness, difficulty with activities away from your body or overhead. As I mentioned, you may have an asymptomatic rotator cuff tear. Older patients, and even in the setting of no trauma. Some of the exam findings that we look for: pain, weakness with especially external rotation or rotating your arm in an outward direction, or bringing it out to the side away from your body. So weakness in those directions can be an indication of a possible rotator cuff tear. And in some instances, if the tear has been there for a while, you can actually develop some atrophy that we can see in the back of the shoulder on exam and observation. So some of the treatment considerations if you do have a rotator cuff tear, one of the first things, again, is to note whether it came on in a traumatic or a degenerative fashion. If you had a specific injury, a fall would be a good example. If you lifted something too heavy and felt a rip, a pop, or a tear in your shoulder, that would give us some indication that your rotator cuff may be involved. The difference between a full or a partial thickness tear, as I mentioned, partial thickness tears only involve a certain part of the rotator cuff. They maybe don't go all the way through the rotator cuff, and they tend to become more common as we age. It's important to differentiate between partial thickness and full thickness tears because it really helps to determine the treatment path. Most partial thickness tears can be treated non-operatively until they progress to a certain point. Once they involve more than half the tendon, then you start moving from conservative into maybe a surgical management problem. Some of the other treatment considerations, the full or partial thickness tears, we try to determine what the risk of progression is. And so if you have a partial thickness tear, we try to determine how big that tear is, how much of the tendon is involved, what your daily activities are, and we try to determine what your risk for progression is, or what's the chances that it's going to get worse. We look for the overall condition of your shoulder. Some patients will come in with a torn rotator cuff, but they have other issues that kind of override the cuff tear. They have a frozen shoulder, or they have a fracture, or they have arthritis, and all these things can factor into how we treat rotator cuff tears. We consider your job requirements and how much demand you're putting on your rotator cuff. And then we always try to think of the ramifications of the do-nothing option. What if I have a tear but I decide not to do anything? We try to determine, based on your age, based on your activities, based on the location of the tear, the size of the tear, we try to lay out for you what your risks are. If we make a recommendation, you decide, well, I think I'm just going to do nothing for now. Sometimes that's okay. Sometimes you're putting your shoulder at more of an increased risk for further problems down the road, and we try to help you make that determination. So as I said, partial thickness tears at any age can oftentimes be treated non-operatively. We do activity modifications. We try to avoid especially heavy lifting until the pain resolves or gets better. Anti-inflammatories can help, especially in an acute setting, to get the inflammation to settle down, can help with the pain as well. Injections can be considered. If we think there's a good chance that you're going to need a repair, we'll oftentimes hold off on doing an injection because it can, in some instances, affect your surgical outcome or make you at a higher risk for a failure of your repair if we do an injection too close to the time of surgery. A home exercise program, again, can help to strengthen the cuff, get you over partial thickness tears. Formal physical therapy is sometimes utilized in the same regard to try to strengthen the rotator cuff. Sometimes just time alone is going to help with the symptoms of a partial thickness rotator cuff tear. When we are treating you for a partial thickness tear, we try to make you aware to be cognizant of any progressive symptoms. If your pain's getting worse, if you're developing any weakness in the shoulder. These could all be indications that the tear is getting bigger and maybe pushing you more into the category of now I might need to consider surgery for my rotator cuff tear. Full thickness tears, especially when they occur in a traumatic setting, are kind of a different animal. If you have a fall or you lift something heavy and you feel a rip or a tear, and we went from having a shoulder that worked perfectly normally, you had no pain, no problems, no weakness with the shoulder, and all of a sudden you have an injury, you can't lift your shoulder, you have significant pain, and you show up in our office. If your exam is worrisome for a rotator cuff tear, we will usually go ahead and progress your workup to get an MRI, and if a full thickness rotator cuff tear is found in a traumatic setting, very often surgery is going to be the best solution for a good long-term result. Surgery may also be appropriate for the partial thickness tear that progresses or partial thickness tears that fail non-operative treatment and continue to cause pain. We will also consider rotator cuff repairs when there's other pathology involved that require surgical attention. And so if you have a biceps tendon tear or labral tear, chronic impingement, AC arthritis, something else that would require surgery, if we go in and we see a rotator cuff tear that is more than half the thickness of the tendon, very often we're going to consider fixing it right at that time, and that's something that we would discuss prior to surgery. Rotator cuff tears that are very large and are either not diagnosed or go without surgical treatment, either because of patient choice or because it's a tear that's gotten worse over time without any real obvious symptoms, can be very problematic. If we see a large rotator cuff tear, we think in terms of a ticking clock. You have a certain amount of time that you can get in and actually repair the rotator cuff and hope for a good result. The more time that goes by with a large tear, the less likely it is we're going to be able to repair it and get a good result. And in fact, some rotator cuff tears, if left alone for too long, can become unrepairable in that the rotator cuff tissue becomes retracted, can no longer be brought back into position where it can be repaired. They can be, the rotator cuff and surrounding soft tissues can become scarred in, and worst of all, the muscles, the rotator cuff muscles can go on an atrophy. And once you've gotten to the point where you have a chronically torn, retracted rotator cuff that's scarred and the muscles atrophied, you start getting into the unrepairable zone. And that can be very problematic. Massive rotator cuff tears that are unrepairable can lead to arthritis and eventually may require a shoulder replacement, or in the setting of a torn rotator cuff, actually a reverse shoulder replacement, which is a little bit different than just your standard shoulder replacement. So a little bit about rotator cuff repair itself. These are typically being done as outpatient surgeries now and have been for many years. If you had a rotator cuff repair many years ago or know someone that did, they used to be done in an open fashion with a large incision, a lot of soft tissue dissection. Many patients will tell you that it was extremely painful going through a rotator cuff repair. Over the years, we've developed better arthroscopic techniques, and for the past 15 years, I've been repairing rotator cuffs almost exclusively arthroscopically. The arthroscopic repairs have certain advantages. They tend to be a little bit easier recovery in terms of pain. However, it's important to keep in mind that the healing times are similar. When we repair a rotator cuff, what we're doing is we're reattaching the torn tissue back down to the bone, and we're requiring over time that that tissue actually heals to the bone in order for it to get a good, solid, long-term healing result. The post-operative recovery after a rotator cuff repair is one of the more daunting features of considering a rotator cuff repair, in that it's a fairly long recovery. The first 6 weeks after a rotator cuff repair, we're going to ask you to do only passive activities, which means that you can't raise the arm away from your body without assistance. And so we get you started in physical therapy. The therapist moves your arm, shows you some ways that you can do it without lifting it on your own power. And otherwise, you are typically in a brace that holds your arm by your side and protects your arm from moving away from your body during the first 6-week period. At the 6-week point, we usually progress to active assisted and active range of motion exercises with physical therapy, which means that you start raising the arm on your own, but at that point you're still not using it away from your body. You're not lifting with it at 6 weeks. We're just working on getting all your motion back. By 3 months after surgery, we would expect or hope that you would have all of your motion back, but at that point you still don't have a lot of strength in the shoulder. The next couple of months after that is progressive strengthening exercises, usually in a controlled setting, and then progressing to home exercises over time that you will continue to do even after you have returned to most other activities. We usually think in terms of about 5 to 6 months to getting back to most activities after a rotator cuff repair. The other thing to keep in mind after a cuff repair is, although we get you back to most activities by 6 months, people will still exhibit some symptoms, and they may not feel like they've experienced a full recovery back to their normal shoulder for even up to a year. And during that time, we'll ask you to continue with your strengthening exercises on a continuous basis. So with that, I'm going to wrap up my formal talk here and address some questions. We did get some questions that came in beforehand. I'll address those first, and then we'll move on to any questions that came in while we were talking here. So the first question that we had is regarding the COVID situation and surgery. I already addressed that. The next one is, why did you decide to become a doctor? I went to Texas A&M University, went there primarily to study engineering and to play football. And during my freshman year, I had a pretty severe knee dislocation, resulting in 4 knee operations over the years and a permanent neurologic injury, which I sustained a injury to my perineal nerve, so I was unable to dorsiflex or raise my foot after that. And through the surgeries that I went through, my interactions with orthopedic surgeons, I decided that I would try my hand in orthopedic surgery. So that kind of set me on my path. My personal experience in talking to some of my partners and other doctors, we often find that that's the case, that it's something that you went through or some experience that you had that kind of leads you into medicine. Next question is, when is it time for me to see an orthopedic surgeon for shoulder pain? Again, some of the things to look for if you have an acute traumatic injury and you went from having a normal shoulder to now I got a painful shoulder that I can't move, I have weakness, I have numbness. So an acute injury followed by pain or weakness, I would say, is a reason that you probably want to get in sooner rather than later. For those that have a more insidious onset of pain that just kind of comes on with no specific injury that just develops over time, maybe an overuse injury, you can try the things that we mentioned. You can do modify your activities, avoid things that hurt, try some anti-inflammatories, some home exercises. If you find that the pain is getting worse or it doesn't seem to be getting better, that would be another time to go and seek orthopedic care. Next question, how do I know if I've torn my rotator cuff? I think we touched on this already, but sometimes it's very difficult to know if you've torn your rotator cuff. There's things that make us suspicious. Again, the history of a specific injury, either a fall followed by pain and weakness. If you lift something too heavy or try to lift something overhead, you feel a pop, you feel a tearing sensation, you feel any acute onset of symptoms. Those are all indications that you may have a rotator cuff tear. And in addition to that, we again see the atraumatic rotator cuff tears, those that come on and develop over time. Those can be either an overuse problem or they can be something that has to do with your specific bony anatomy, and that would be something to be evaluated. If you have pain in your shoulder that develops over time, especially if you have trouble using your arm away from your body, those are all indications of possible rotator cuff tear. So the next question is, I have trouble lifting my arm over my head. Could something be wrong with my rotator cuff? Again, that's one of the telltale signs. Difficulty with activities away from the body or overhead could be a rotator cuff tear and should be evaluated. Next question, what are the non-operative treatments I can try for my shoulder pain? Non-operative treatments, one of my favorites would be the home exercise program with elastic tubing. With the elastic tubing or bands, you can titrate your resistance. You can use more or less resistance based on your overall strength and what you can do without eliciting too much pain. So a home exercise program to try to build strength is one of the things you can try for your shoulder pain. Use of an anti-inflammatory if you don't have a contraindication for it, if you don't have a history of GI bleeds or ulcers, if it's generally okay for you to take an anti-inflammatory, that's something you can try short term. If it seems like it helps, then you could continue to take it. If it's not helping, or if you're requiring more, you probably got to have your shoulder evaluated. What are the surgery options if other treatments don't work? Surgery, that's kind of a broad question. Surgery is based on your underlying pathology, so the specifics of a surgery are going to be dependent on whether we're treating you for a rotator cuff tear, a biceps tendon tear, a labral tear, arthritis. We didn't really discuss arthritis very much. That is an entirely different topic all on its own. For people that have very advanced arthritis in their shoulder, have failed non-operative care, shoulder replacements are sometimes the answer. In the setting of a arthritic shoulder without a functioning rotator cuff, then we start thinking about a reverse shoulder replacement, which is a different type of shoulder replacement where we actually invert the anatomy and take the socket and turn it into a ball, and we turn the ball into a socket, but it's a better solution for those that don't have a rotator cuff. What is the recovery like after shoulder surgery? Again, very dependent on the type of surgery that you have. If we do a shoulder scope without a repair, again, the recovery tends to be a lot quicker without specific restrictions. And so you leave the facility. Sometimes we tell you that you can move your arm right away. We give you a sling to use for comfort, but you start to move your shoulder and return to activities, oftentimes just based on the amount of pain that you're having and what you can tolerate. And again, without a repair, many shoulder surgeries have recovered by 6 weeks. If you do have a repair, again, your recovery is going to likely be much longer. Next question is, how do I know if I have an overuse injury? Usually that's something that you're going to be able to tell me better than I'm going to be able to tell you. If you can identify a specific activity that you've either changed or increased. We see people that get into a new weightlifting program. We see athletes that start up their sport after an off season, specifically overhead athletes. We see throwers, we see tennis players, we see swimmers that come in. Those are some of your classic overuse athletes. We see dancers that come in with, especially gymnasts that come in with shoulder pain, and it has to do with over-aggressive training regimen or insufficient rest. So when we were talking about overuse injuries, the most important thing to do to address the problem initially is just to stop doing whatever it is that caused the problem in the first place. You know, in Wisconsin, we see this time of year, we see people come in with overuse injuries after shoveling snow. We see people using a leaf blower for too long, raking leaves for too long, putting up Christmas lights. All these type of things can cause an overuse injury. So oftentimes overuse injuries, I'm going to ask you a bunch of questions. I'm going to try to get to the bottom of it. Sometimes it's an aha moment when you start to really think about what you're doing before the shoulder pain came on. You can sometimes identify what it was. Sometimes overuse injuries just happen and we don't know exactly why. So let's see, the next question. Can you remove arthritis from your shoulder, and if so, how? So as an orthopedic surgeon, when we're talking about arthritis, there is generally two different types of arthritis we think about. One would be an inflammatory arthritis, and this would be something like rheumatoid arthritis. So if you have an inflammatory arthritis, that's something that is often treated with medications. We do at OSMS have a team of rheumatologists, which is another great thing about our practice here, is that when we do see someone that we suspect of an inflammatory problem, we can send them right down the hall. They can see a rheumatologist here. So arthritis causing shoulder pain, if it's an inflammatory arthritis, that may be something that medications alone are going to make better. When we talk about degenerative arthritis, which is something we see very commonly in our practice, especially as we start to see older and older patients, arthritis either from overuse, from previous injury, from previous surgery. Arthritis is some condition that causes the cartilage in the shoulder to break down, and so you lose the protective articular cartilage. And when that happens, you start to get bone-on-bone contact, which causes pain. The body responds by forming bone spurs, which can limit your motion. Soft tissues will contract around arthritic joints, which also causes you to lose motion. And arthritis is generally a progressive problem, and so when one has arthritis, it's not something that you ever get rid of. Arthritis tends to be progressive. In certain circumstances, we can debride arthritis or go in, especially if we're in your shoulder doing an arthroscopic procedure for some other purpose. If we see some articular cartilage wear, any loose flaps of cartilage, we may take a shaver and smooth those down, but ultimately we can't replace cartilage once it's worn down. The end result of arthritis, when it progresses to the point where non-operative treatment is no longer working for you, so you've modified your activities, you've done anti-inflammatories, you've done physical therapy, we've tried injections, and you have an arthritic shoulder that's affecting your ability to use your arm, do your activities of daily living, then we start thinking about shoulder replacement. Ultimately, really the only way to get rid of arthritis in your shoulder would be a shoulder replacement. Shoulder replacements are very good operations at relieving pain, and it's really the number one and most important reason that we consider shoulder replacements is for pain relief. They can restore some function, but the restoration of function is not nearly as reliable as pain relief. So arthritic shoulders, fail non-operative care, in situations where the pain has become bad enough and affecting daily life activities, shoulder replacement may become the best answer. Next question. My shoulder pain is improving over 6 weeks with no traumatic injury. How long should I wait to see an orthopedic doctor? I think the key to that question is that you say your shoulder pain is improving. I would say any problem that's improving, it would probably be okay to hold off as long as you're trending towards improvement. If you stop improving, or if you improve for a while, that plateaus and you actually start to get worse, indication that it would to seek an orthopedic opinion. So if there's no history of an injury, pain that is getting better, I would say the anti-inflammatories and conservative management that we discussed is all appropriate until such time as the pain stops improving or starts to get worse. Next question, I have pain from my elbow to my shoulder. Is this shoulder related? I have been scoped and had scar tissue cleaned out about 6 years ago. There's pain and at times weakness. When we think about radiation of pain from the shoulder, there are instances where we see pain that goes further down the arm than just the shoulder itself. A shoulder problem should generally stop at or above the elbow though. So if your pain is stopping at the elbow, it could very well be related to your shoulder. If it goes below your elbow, especially if it goes into your forearm, or if you have any symptoms that are going down into your hand, very rarely is that associated with shoulder pathology. And so just about every day in my office I'll have someone that comes in for shoulder pain, and when you take the history you'll find out that, oh yeah, my shoulder pain shoots all the way down into my hand. When we hear that history again, I mentioned it early in the talk, but we start to think about problems being higher up, specifically in your neck. If you have a pinched nerve, herniated disc, arthritis in your neck that's pinching on a nerve, you're going to feel that pain wherever that nerve is going. And so if you feel pain that goes below your elbow and into your hand, oftentimes we look at the neck as a potential source for that. So with your specific question about pain that goes from the shoulder to the elbow, it could very well be that it's coming from the shoulder. Scar tissue is a general term that gets thrown around. I hear scar tissue being cleaned out. I don't know if we're specifically talking about a bursa, if we're talking about some scarring in a tendon. And so scar tissue in general is kind of a difficult thing to address without being able to do an exam and really see where that might be coming from. I would say if there's weakness involved, again, it could be a tear in the shoulder, or weakness is also sometimes associated with neck pathology. So a herniated disc or arthritis in the neck may cause weakness. I would say for this specific question, if you've had surgery before, if you're continuing to have problems, I would say that probably another evaluation in the office would be appropriate for that condition. Next question, is it common for shoulder pain to be most noticeable or very noticeable at night during sleep? That's an excellent question. That's one of the things I think I left out when I was talking about the history, but a pattern of pain at rest and pain at night is an extremely important part of the history. If you have shoulder pain that started without a specific injury and occurs primarily at night, especially if you have difficulty getting comfortable in bed, or if the pain wakes you from sleep, very oftentimes this turns out to be bursitis. Bursitis is notorious for causing night pain, and so when I hear about pain at night or pain at rest, that's one of the first things that comes to mind. And so you know, the other thing that I would think about for pain at night is, again, cervical spine. And so if you have a pinched nerve coming out of your neck, positioning of your head on your pillow, or the way that you're sleeping, sometimes your neck gets twisted or torqued at night, and that can cause some pain in your shoulder. But Again, if the pain is in the back along your shoulder blade, that would lead me more towards your neck as being the problem. If your pain is out on the side of your shoulder or right in front of your shoulder, that would be more of an indication of a bursitis problem. So bursitis, again, can be treated with inflammatories, avoiding painful activities. It is one of the things that we'll do injections for in the office, especially if it's been present for a while and doesn't seem to be getting better. Bursitis that we inject in the office that gets better and recurs, and so you get relief from the injection, but some time goes by and the pain comes back. Depending on how much time you got relief, we may consider another injection, or if you've had multiple injections with temporary relief and pain that continues to come back, that may occasionally require surgery. Surgery for bursitis, what happens over time is that the bursa, which is typically a thin tissue between your rotator cuff and the acromion above it, can become thickened and chronically inflamed. And so in these instances with recurrent pain or pain that comes back even after an injection, scoping your shoulder and removing that inflamed, thickened bursal tissue will oftentimes get rid of the problem entirely. One of the reasons that people get bursitis is what we call impingement, and so depending on your bony anatomy, the acromion, which is the bone that sits right above the rotator cuff, can sometimes stick down in the front. It can narrow the space between the bone and the rotator cuff, and it the bursa and the rotator cuff tissue. That can be one of the things that can cause bursitis in the first place. And so if you come in and we diagnose you with bursitis, part of your workup would include an x-ray. And on one of the specific views of the x-ray, we can see what your acromial anatomy looks like. And so if we see you have a big curve on the bone, or that you have a big bone spur in the front of that bone, if you haven't had a specific injury or we don't suspect a tear, we'll still treat you for bursitis. But knowing that you have that underlying bony condition, we may anticipate that we're going to need to do surgery for that in the long run. When we do surgery for bursitis or impingement, one of the things we do is we flatten off the bone, the acromion. And so with a burr, we come in and we remove any bone that's sticking down into that space and narrowing the space that could be causing the bursitis or the rotator cuff tendonitis and pinching on those tissues. Next question. Okay, I'm getting notification that there are no more questions. So again, I want to thank you for joining us tonight. I hope that we gave you something to think about, something that might help to explain the shoulder pain you've been having. If you feel that you have pain or a problem that would benefit from being evaluated here in the office, you can go online at osmsgb.com and request an appointment, or you can give us a call here at the office, and we'd be happy to set up an appointment and see you. So thanks again for joining us this evening.